Before I begin, I'd like to thank our board members, our Director of Marketing, Carly Clemens, and her fabulous staff for putting on this show. I'd also like to thank our sponsors, Trade Lawn of Vesta, Harvey Klein of Red Uniform Taylor, and EMS World Magazine. We're going to get underway with our opening keynote speaker. He is the President, CEO, and co-founder of ESO Solutions. Welcome, Chris Dillie.
Good morning. Good morning. Well, thanks for having me. Like I said, I'm the President and CEO of ESO, and this is probably going to be a little different because I'm going to take off that hat and put back on my EMS hat. My history, I came from started fire, went EMS. I've been on both private and public sides of that, and then we built this company off of that. The failures that we saw in our own careers. I'm going to kind of move away from what ESO does. So you're not going to see a whole lot of ESO-related items in here, and talk more about where, as I believe, the industry should be going. And some of these will bring out some of my failures where I'm not today that we want to go, as a lot of other people, I believe, should want to go. We're also going to talk a little bit about mobile health. Obviously, everybody's looking at that now, so I think that's another interesting topic, especially in the way of technology and what they can do in that area. So what I want to do is kind of start with a little exercise. So, as an organization today, for the EMS providers in the room or the mobile health providers in the room, in mobile health or otherwise, what are your key differentiators? What makes you different than either your competitors next to you or the rest of the industry? So let's say mobile health. What makes you different than home health? Mobile. So we're mobile, right? We have ambulances. We're there 24/7. We're mobile. Other things. Come on, you guys have got to be selling hospitals or somebody else in this stuff, right? How else are we different? Well, I've done this one a couple times now. Call center. So you have the ability to take in patients effectively and hopefully move them out effectively. So I've done this one a couple different times in this question, and the funny thing is, I'll sometimes even get up to 8 or 9 answers. But one that's never in there is technology. Nobody ever says one of our key differentiators as an industry is technology, which is interesting to me because if you look at it, it worked really well for some of these companies, right? So Google and Amazon. Amazon has changed the way we all buy. They've changed the market completely in the way what things cost and how we do things. Apple is pretty obvious. Tesla is revolutionizing the way we think about vehicles. The interesting one there is McDonald's. That's an interesting one. How did they revolutionize anything through technology? So if we looked a little bit at McDonald's, you'd say, well, the history of the drive-thru. Let's look at that. So it was originated in 1947 in Missouri on Route 66. McDonald's actually was pretty late to the game in the drive-thru business. They came in 1975, but now they're to the point where their drive-thru business makes up 60% of their revenue. So from something that didn't exist and now 60% of your revenue, big jump, right? So they started investing very heavily in it. So they started, just driving cars through there, but then they put two-way intercoms in. Then they went to point of sale systems, so they got very involved in software. How do we drive the process better? They put multiple windows in. Now we have multiple lanes and multiple windows. You have a confirmation board, all LCD, to make sure that your order's right and they get these right the first time to keep the process working quick. So they're always looking for ways to improve that. So they use technology to push forward a company that really has nothing to do with technology. It's food service, right? So why are we talking about McDonald's? Well, I'll tell you that one later. We'll try to tie this back in later as we go through this. What we'll do is we'll go into mobile health and technology and talk about some of the challenges and what we see going forward in this area. So if you look at your challenges in mobile health and where you're going, it's an evolving, undefined practice of medicine, right? So it's kind of the wild, wild west. People don't exactly know what it's going to be or what it will become. So you're kind of always shooting at a moving target. It's completely disconnected from the rest of healthcare. How many of you today can say you're connected to PCPs, to skilled nursing, to home health, and to hospitals? Nobody, right? It's just, we are not connected to the rest of healthcare. So going out to manage patients mobilely, when we're not connected to the rest of it, gets pretty tough. We have limited access to all the critical information we need. And we cannot track patients well. So one of the big problems I'm sure all of you are seeing is I take a patient for a hospital. Let's say we're going to do a readmission reduction. How do I know that that patient didn't go somewhere else? Is there any way of tracking that? And that's one of the first things a payer would want to know and a hospital would want to know is, where are my patients going? Are they costing me money? Are they ending up in different places? And that's very difficult to track. The biggest one I look at is who's paying for it and how do we prove to those payers that we can make a difference? That's where kind of the rubber hits the road. We've got to prove that we can make a difference with this population set. And at the same time, we got to find a payer that's willing to pay for it, and usually up front, because we don't have any results yet. So it's a chicken and egg situation. So one of the things I'd say is we have to have information, right? We need to know all about that patient. We need their health record. We need to know everything about them. We need to know their diagnoses. We need to know their fitness levels. We need to know BMIs. We need to know a lot more on patients so that we're able to be effective in mobile care. So to me, the dream would be we connect to the rest of the healthcare world. Interoperability, right? That's the words that they use on the healthcare side. So if you'll get meaningfully used, phase 2, interoperability, it's key. They're all talking about it inside today. Going to work with your hospitals and connecting and making sure you're getting your data in and they're getting their data back out to you in a way that we can be effective, I think is key. A suite of applications and technology for managing patient populations, not managing incidents like we've always done, managing patient populations, which is very, very different, right? We need a new platform. There is no mobile health EMR out there. There's a few different ones that home health has used. We've looked at those. They don't meet the needs of this particular environment. So there really isn't today a true mobile health EMR to go use and manage a patient over time. And then we need one data set. If we can't do some benchmarking, if we can't look at our industry and see how we're doing, if there's not a good data set out there for this style of business, similar to what we have in Nemesis, it's going to be really difficult to prove that we can make a difference, right? Because any hospital system you go into, if you've got, let's say, 50 to 150 patients, for them, that's a cute little thing. That's not a real program. If you can come and say, not just me, but all of the people who are doing this like me, and the 10,000 patients that went through the same thing, and here were our results, now you have somebody's attention. So I look at the Nemesis side of the world. While Nemesis hasn't been perfect over time, and I think we all agree with that, it does give us a common data set to start benchmarking off of and look at, as an industry, how do we push some of the things we want to do forward. So with that, if you look at some of those technologies or applications that I think we need as an industry to go manage patient populations, first is patient scheduling. Patient scheduling is not dispatch. They are very different things. To manage mass patient populations, you need a true tool that you can manage patient populations. You need it to interface with your dispatch system because you need to get that patient taken care of by somebody. But at this point, you really just need the ability to manage a full patient population. And you've got to be able to receive that patient from a lot of different places. So if you were to do, let's say, a managed Medicaid contract, they could easily, in any region of the country, dump you 5,000 patients overnight. Who in here is ready to take on 5,000 patients overnight? It's not just a people problem, that's a technology problem. You could make that efficient enough to go do that, and what a great opportunity to go do that. Hospitals, case managers, EMS, that's a group that needs to connect into this. We always think about ourselves as EMS, but these are two really different business lines and should be used differently. Public health, hospice, home health, we know a whole lot of these folks. If we could integrate with them and be able to take patients from them effectively and work together and collaborate on patients, it's a lot different. I think the next one is that mobile health EMR we talked about. Today we manage incidents. We shouldn't be managing incidents, we should be managing patients. So the record should begin the day they're born and end the day they die. Not incident start to incident end, and let's just do that over and over again for the same patient. It all should flow into one master longitudinal record, and you can look across the patient's history. So anytime you come there, no matter who you're working with, you see all of that information right there within your EMR. So if your neighbor next door in another EMS system picked up that patient, why wouldn't I see that record? If the hospital had seen it, why wouldn't I see the discharge summary? Well, why wouldn't I be able to communicate with the PCP with this? So you really got to integrate this into the entire healthcare system. And that goes back to that communication or interoperability. We also need to be able to look at decision support, because this isn't something that EMS is built to go do. Our training doesn't say, let's look at long-term health of patients. So you need some decision support tools within it, and then you need to know, what is their status in the program? How do I trend how they're doing over time? And then the third one, and this one gets a lot more interesting, is remote patient monitoring. This is the area in the industry that things are really moving quick, right? So we would want to be able to manage patients centrally in one location, but be able to look at a lot of patients. How many of you, like me, probably early in your career, sat in front of a telemetry screen as part of your paramedic training or other things at a hospital and looked at about 18 patients all at once? That wasn't great a few nights. I can't imagine once we did that full time, but that's something that we should be looking at in general. How do I manage these patients over time in a more automated fashion where I can take on more patients? If we're going to send a person out to see every one of them, we're going to die pretty quick. We've got to be able to look at them in a different way. So I think we need to be looking at things like their blood pressure, their heart rate, all of the normal vitals, but also exercise programs, BMI, and a lot of other things. Are we trending in the right directions with our patients, and are we helping them? So how would we monitor those patients remotely? Well, right now you've got wearables. How many of you got, I'm wearing the Fitbit. I think my wife would argue I'm not using the data I'm getting from this very well. But a bunch of us use the Fitbits and other things. The Wall Street Journal recently did a thing that says wearables have capped out on the consumer side. This is about as good as that market's going to get. It's interesting. I don't know if I necessarily believe that, but what they were going towards is they think the next side of wearables, which you go to the health side of the world, where now you're into FDA compliance and you go much further with these things, is kind of that next rung. So instead of just doing it for how many steps have I done, how many stairs have I done, maybe heart rate, now let's look at true wearables as part of your vital dynamics that you could send to PCPs and other places. So the wearables is one good way to get some data. How about the new smart thermometer, the Fever Smart? There's an interesting one. So this one, right onto a patient, tracks it, sends it up through their smartphone, and can be tracked at all times. So here's a way to track temperature over time. So any post-surgery patients, kind of be an interesting thing. They go home with that for 10 days. We can now track their temperature and not send somebody out every day to go see them. COPD. New diagnostics where you can actually put a wearable on the patient and get lung expansion and be able to look at respiratory effort remotely. That's another patient population we have a challenge with. You look at maybe even the pneumonia group and some other ones that you could look at remotely with this. So the biosensor side, the FDA has cleared quite a few over the last 2 years. We think this is this area that, it's still yet to come. Once the FDA started clearing things, you know things will start moving quickly. So I think there's a lot of different wearables out there that could get pretty interesting. I like the digital pills. I think that one's really interesting, especially how they respond to digestive juices. But one of the big problems are just people taking their medicine, right? So readmission, when you're looking to reduce readmission, it's been shown up to 77% of patients were non-compliant with their medications of their readmissions. Here's something that would allow us to track that, to see how they're doing. And it's not just that you take your medication, did you take it at the right time? You took it at 7 o'clock in the afternoon, not 7 o'clock in the morning. That's not what we asked you to do. Right now, I would say we don't even know that. We just know whether they take it or not based on whether they tell us they take it or not. Right? So I think this is another one that gets very interesting as we go forward. So how will we get the data from these wearables? That becomes a big problem. So everybody starts thinking next, like, what kind of infrastructure goes with that? What do we have to do to actually get all of that data and be able to use it? It's pretty simple now, right? This is the hub. These become the hub of everything that we do. And interestingly enough, even grandma, now 50% of them almost have a smartphone, not just a phone, a smartphone in recent studies. So you start looking at what part of the patient population actually has a smartphone and has the hub we need to make this happen. So we're no longer talking about bringing in Time Warner Cable or AT&T or somebody else to get broadband internet access into a house just so we can stream some data out of it. Use their equipment. Apple's Health Kit. How many people have heard Apple's announcement on the Health Kit? So Apple's going to go now start trying to be a hub for some of this data as well. All of these different app manufacturers who are putting things out to do things in an aggregated way where you can go grab data off of this. And it will be available to anybody that they allow to have it. So in your case, it could be the patient saying, hey, we're going through the Apple Market. Great. I'm making X, EMS service or ambulance service a note on this thing and allow them to see my data. Another great way, long-term potentially, to get this data and make sure you have it. So to me, all of this means way more data in that patient's healthcare record. And once again, if we go to the longitudinal record, not the record we have today, when you walk in the door, you have a whole lot of information to start talking from. Like what happened 3 days ago when your blood pressure was off the charts, your heart rate was up, and everything else, and what was happening at that moment. Why haven't you been taking your pills on time? What's going on with your temperature? You've seen spikes up and down. What's going on with you? It's the ability to track a patient and not have somebody in the home every day. And the home every day doesn't work anyway, right? You get them at one point snapshot in time. This will give us continuous data over time to start trending. Oops. So the next part I always look at is what are the next trends in our business? We look at mobile health and sometimes, I look at it and I say, I don't know that EMS, we are the right providers for mobile health in certain ways. And that's just kind of the frank, just a belief. Nurses got a strong union. There's a lot of challenges out there. So being the providers of it is pretty tough, right? It's tough to find your payer. It's tough to do a lot of things. But there are some areas I do think we have really good opportunities. One of them being much bigger than just mobile health in general. And it's exactly, I think, what you're talking about. So as an industry, what is our brand? If you'd say if somebody from the healthcare market, a CEO of a hospital, or the public in general, if they had to look at brand us, what would they call our brand? Or what would they say about us? What would they think we are? Rapid responders.
Access.
Access is a great one. Any other ones? I'd say both of those are really close. 911. Do we have a better brand than 911? Now we have to share it with police and fire, but that is our number one brand. Everybody knows us as 911. If you even Google 911, you see all kinds of interesting, but it's all about that first response, getting out there, seeing, either treating patients, mitigating, police, law enforcement related incidents, or fires. So 911, a really good brand for us. So you remember that McDonald's slide we talked about? They came late to the game. 60% of their revenue is now there. And they went to two-way intercoms, point of sale, real-time monitoring of patients, or of monitoring of the drive-through process. They put in multiple windows, and they order feedback systems. So let's look at us in 911. We came around, first one was in 1968, the first 911 call. Evolution of it, two-way radio systems. Then we put headsets on the dispatchers. We wanted them to look like drive-through workers, right? And then we put computer-aided dispatch systems in place, so software. Same as the point of sale type of thing. We put in EMT, we display to targets, right? We're all looking for how quickly we get calls out. We're statusing all of that. And today we do 240 million patients a year through that, or people through that. You think about that, it's grown our business dramatically, hasn't it? 911 as an easy access point has grown our business similar to what McDonald's saw. So what have we done with it lately? So over the last 5 years, what have we done with 911? I think we're now looking at text to 911, right? That may be one of our next big ones. We have not done much with what we own as a brand, 911. And we're all in business. This group specifically is in business. We've got a great thing we can use. How are we using that to grow our business? So with that, what are our key skills? As an industry, what do we do well in this area? Well, I'd say logistics. We are a logistics company in many ways. We triage the unknown in a very systematic way and do it well. We consistently get the right resources to the right place. And then on top of it, we're able to accomplish them in a very timely manner, which isn't always very easy. So you look at the payer side. If you talk to CEO of Aetna, this is a big mystery to them. They don't know how to go do this. They don't know how to manage patient populations. And right now, all they have is a little bit of payer data. They don't have the complete picture. They also don't know of anybody else in healthcare. that can do that rapidly and well. So it's interesting. Now, the other part I'd say is, if not for our other skills, one of them being healthcare providers, UPS could come take our job, because they're pretty darn good at the logistics side as well. So that healthcare skill set we have makes us very, very different. It's something that allows us to do something different than anybody else, and I would say that's a brand we should be building on. So why not something like this? I don't know if it's 910, but if you have a healthcare need, why wouldn't you call a master number? And now you get the experts in healthcare logistics. We're going to take care of you. We're going to find and make sure you get where you need to go. As a federal government, we spend more money as a country on this problem than any other. Why haven't we done the 1968, let's make the 911 call and let's give people better access to emergency healthcare? Why now not look at the other side of the house and say, why would we also not do that for healthcare in general? It's got to be organized better. It is not organized well now. So, does this look familiar? Everybody attacking the patient, and the patient having to figure out where they go in any circumstance, right? So the payers are going at them, the nursing homes are going at them, the EMS, we go at them, PCPs, pharmacies, all sides of the hospitals, they all kind of converge on the patients, and we're all doing it independently. Nobody really works together on any of that unless you're within a healthcare system, and then their biggest worry is the patient getting outside of their system because they have no control over it anymore. So why not put in that hub of healthcare, a call center, a 910, something that allows you to manage patients at a whole different level, but not just manage your patients. Manage way more than that. So you need patient navigation and scheduling. We talked about that patient scheduling application. You need telemedicine, right? So you've got to be able to remotely touch patients in a whole different way. What if we were that hub for telemedicine experiences? You need to be able to remotely monitor patients. And you need payer integration and navigation, which if you look at any of it, for my company, what I do, I always follow the payers. Following healthcare systems will just have you chasing what they're chasing. Payers are what drive our industry, and if you're following the payer, you're probably going the right direction. So we look at the payers. So we want to make sure the payer side was very involved in this. The resources for this would look like a lot of logistics experts and then some healthcare experts. So you're looking at schedulers, dispatchers, EMTs, paramedics, nurses, mid-level practitioners, touching all levels of it so that you're able to manage patients at a much better level. Something more like this. That patient on their smartphone with the tools that allow us to look at, are you keeping up with your exercise programs? Are you doing all the things you're supposed to be doing? If not, we need to either get you where you need to go or send somebody to you. But something's going to happen next. You're not taking care of yourself. It's time for us to get you where you need to go next. That could be pretty darn powerful, right? So with this, we want to be collaborative. We want to work with the rest of the industry. This isn't the thing we're going to go do it all. If EMS was involved in this, I'd say we'd be providers for very little, but coordinators of all, which would be really fun. That's a much bigger picture than I think most of us look at every day. So if we were able to collaborate with payers, we monitor programs for their patients. We can ensure effective patient navigation, which is huge to that group. And we can surface data they don't have access to. So if you look at Aetna, Blue Cross Blue Shield, and some of the other ones, all they have is payer data. They cannot tie clinical efficacy at all to the dollars, and that's driving them nuts. It's where you're valuable. Your data is way more valuable to them than you are or the services we offer in many cases. It's the data because it allows them to drive their models differently. Collaborate with health systems. So we want to do some of the same things there, and they're always looking to keep that patient within their system. So if we're a hub of that, we can help keep that patient within their system and collaborate with them on that. And then you look at private PCPs. Why wouldn't we be the first alert monitoring system for PCPs? If an ambulance goes there, if anybody goes there or something happens with their patient, if their patient's blood pressure's out of whack, their blood glucose is out of whack, or whatever that might be, why wouldn't we be that first alert center for their primary care physicians as well and help to coordinate some of that work? Also collaborating with home health, hospice. Look at the night and weekend backup related stuff. Now they have somewhere where those patients, they hand out every time they go, if you have a problem, this is who you call, they get us. But now they have a backup within a call center. If you had your mid-levels and other things, you'd be able to take care of patients at a different level. So at the end of this, what I would say is, becoming a hub for our industry in healthcare, not EMS, is pretty darn interesting. And we already have the brand. And we own the brand. It really is who has the guts to step up and do something like that. And you look at, there's some people doing smaller programs on it. I think what Doug and Matt are doing, great friends, and I really think that what they put in place in that area is starting to work, and that's a small regional thing, and that's not a healthcare hub. They're now just a portion of the navigation. I know they want to go much further with that as well, but that takes, you've got to go somewhere much, much bigger. So this is to me, one of those fun things that could be a collaborative effort in multiple places all at the same time. It could be very, very interesting. It'd be interesting to see what the government would be willing to do around it. I lost my clicker capabilities. Great. Questions? Any thoughts or questions?
So you think that collaboration is the key and getting regulatory bodies together. I mean, I think that and changing, weather might be, equally possible.
Absolutely.
Do you think maybe going the private route has a better, more likely, I mean, without going through the FDA and all of those things, go to Apple or wherever the case is, to let private enterprise do it, wouldn't you think that'd be much faster?
Absolutely. Look what Apple, Google, and others have done. They've went around the government 9 ways to Sunday in almost every country out there. It's no longer about regulation. It's about putting something of value in front of customers and letting them decide whether that makes sense or not. So there's huge private equity groups, there are huge venture groups that would absolutely go for something like that because they understand the problem. They're in the healthcare space enough with 12 of their other deals to realize that's the real macro problem. And it drives the rest of their business lines. There's a lot of different opportunities for this. I do believe that at some point, no matter which side of the aisle you're on, this is a problem they've talked about tackling forever, as far as how we go manage this. I don't know that they've seen that solution before. I don't know they've seen what if we navigated patients in a much different way? What if we did put in a 911 style hub for healthcare? Why wouldn't we do that? And then I would say, if something like that was to happen, that's where we are good. We can show that, right? That's the one thing on that whole list of things to do in mobile health that we can check off and say, we're clearly better than any of you.
Yeah, I think they can't do it because whoever would control it would believe that's what the money is. So nobody will allow it to happen. You think about the biggest buildings and stuff in most cities are insurance companies.
Yep.
So one of the blues is not going to let somebody else start the hub. So.
And that's where I might disagree. So a conversation with one of the CEOs of one of the majors says that's exactly what they think they need, and that's what they don't know how to do. So that one of my fun conversations has been that, like, the logistics of healthcare is something we can't find anybody that's any good at. And they talked about UPS and FedEx. Like, they can do it for all of this. Why can't we manage patients that way? Why can't we move them where they need to go? Why can't we control? I know where my patient's at and what they've done and where they showed up at. They can't today, and it's driving them insane and costing massive costs. You look at, as a group, how much more effective they would be if they could just manage the patient populations. And I think, to me, once again, payer side is always the best place to go. I wouldn't go try to sell that to the hospital or health system. You got to go above that, right? This is that you go to the payer side. But I think the key is you look at 911 as a platform, as a thing. Well, we may have 50 different folks and they're providing computer-aided dispatch. We have one 911, right? We've been able to put that in and that's working well. Now you look at some of the cell phone technologies, that has all integrated into one thing. So as you look at enhanced 911, what that's become, each one of the folks have adopted that. So on the EPCR side for us, we all had to adopt them since we had to go over them. So to me, I think it might look like you're left out of a cool business line and something that can move you forward. If you don't, it always has got to be about value. I think when we try to regulate things or try to go through regulators to get something done, it breaks down a lot. If you're providing value, that's where you make a difference. And I think another great one, health information exchanges, right? Great idea. Let's bring all the data to one place. Let's bring it all there so we can all talk and we can all do better with patients. We'll send a bunch of money down to make that happen. How many of them went bankrupt? How many are not sustainable business models? Well, a big part of that reason is they never provided any value. They sent a bunch of money down and they're not providing value anymore. You know, as ESO, one of the things we've looked at is I can connect hospitals and EMS. And I can do it in a way where it doesn't matter what electronic patient care record you use or what EMR you use. The secret sauce is in the middle. And the thing is, I've got to provide value. I can't provide you just, oh, here's this thing, you know, we hope you use it. And boy, it would be nice if you just ship us all your data. Both sides have got to see value out of it, or it's not worth doing. And I think that's one of the keys, and I think that's where health information exchange went wrong. There is a lot of value in connecting all of the pieces. But if you don't get the pieces in and make them stakeholders in it and put some skin in the game to go make it happen, it's just another thing I got to do. So with it, I would say make sure there's value in it for each side, and that's where I go payer side first, because I can get a massive patient population very quickly, and that moves the needle. If you start from the bottom up, you're going to be doing 50 patient increments or 100 patient increments, and we'll never get there.
How do we get them to switch their thought process and we get paid for an event, to do an event? Now we got to get them to best prevent it. Show that value.
And I think and that's one of those things, it depends on how you go about it. I think the group that goes to an Aetna, to a BCBS, to one of the big ones, and becomes part of them and is part of that muscle to make it happen, has a lot better shot than the one that if we say, we got it all figured out and you should do it our way. It's more about, here's a platform, here's a way to go, here's our expertise, look what we did. Can we partner on this together? Now, it's not a partnership that we're willing to do exclusive forever. But would you even do an exclusivity thing around that for X period of time to get it off the ground, to let Aetna see the value, or one of the other ones to see the value out of that, and then go next? It's a business problem, right? Remote patient monitoring. Is anybody doing remote patient monitoring today? Pulling any data from patients remotely? Does it all feel too far away to be real?
No, for us, it's just how do you get monetized? You know, it's out there and we've seen it. You have a bunch of ways to get it. No, at least at this point, nobody's willing to pay for it.
Yep. And that's where you look at, what are we? Are we the right ones to actually go provide the services in all these instances? Or could we do more around the other side of it? And just my personal opinion, I think we're better suited for the other one. You look at our skill sets, and you look at the skill sets of the folks around us. Home health doesn't have that. They try to, it's hospitals definitely don't have that. We have a thing that they don't. On the other side, we're just another healthcare provider. And the best thing we can say is we're more cost effective and we're local. We're here 24/7. Those are our only differentiators. Well, anybody could pop up with a bunch of Priuses tomorrow and a whole bunch of healthcare workers and go in and try to compete with them. I don't think you can compete with them.
You know, in my experience, yeah, in theory, working with the payers makes sense, but they move at a glacial pace too. So, are you aware? What about the possibility of a fee-for-service model, wherein instead of taking a 911 brand, you brand something of your own privatized brand and deliver something that somebody's willing to pay for out of pocket, kind of a hybrid urgent care model where you're responding to people and bringing the help, that delivery platform to the home. I mean, a merger with some sort of telemedicine component too, but create your own brand. I mean, there's not McDonald's, there's Burger King, there's Denny's, there's everything. So they all have their own platforms. And so, what is the customer willing to pay for, or willing to employ or use? I guess that to me, you can't take down the 800-pound gorilla at once. You got to chip away at it and experiment.
That's right. And I think, and you're right, we couldn't brand 910 or any other thing in a short period of time. What we can do, though, is take the brand we have and use that to our benefit to go do those kind of things, right? I've already shown we're really good at all this stuff. That's what we do for a living. That's our hook to go create our brand. You can absolutely play with that stuff. And I think that's where, once again, if you look at the private equity groups, the big PE firms that have a lot of different toes in the water in other parts of healthcare, think of all the things they're investing in that could make that better and how we could make somebody else's business stronger and collaborate. And that's, for us, it's just, you would want to be a part of the right group. Simple things like, Bain owns HCA, right? Then they get physio control, they're in that Well, does that not help physio? What's going to happen on both sides? So bringing those synergistic companies together and funding could look pretty interesting. Do any of you work with those groups now, some of the high-level PE groups? Sure, yeah, you guys. It's an interesting group. We spend a lot of time around those folks because we think they can make us better. We personally don't need to take the cash, so we don't at this moment, but if you ever need or want to go big, there's just no way to do it without some of that. So they're great relationships to have. And boy, you're amazed in every conversation about how you learn 3 other things you didn't know about that other folks are doing. I definitely, I'd highly recommend, if you're in a growth mode, I would absolutely recommend having those relationships. And only having them with folks that can make you better. Because I've spent, I probably get 3 a day wanting to, once you hit the Inc., the Inc. 500 list and all the other things, everybody wants to send you money. But actually talking to folks who can make your business better, who have shown they've done things in your area, can show you another company that here's what we did there. So for me, I look at what have you done around health analytics, in data, in big data, in other areas. If you haven't done anything around that, there's really no need to talk. You just have money. You don't have anything that can really make us better other than dollars.
One of the things I think we're terrible at is collaborating and sharing data. Because if we actually were able to aggregate data, you might be able to get value around what your proposal is, then be able to present that data to. But everybody silos that information. We don't do well collaborating there, which is not in our best sense to show. But
I'm honest, ESO's a year behind on what we want to do there. We were a full year behind on what we want to do there, and that's, as a company, our mission statement is improve community health through the power of data. And you can't do that with one individual agency. You have to go across all.
Can you do me a favor? I'm not sure if everybody knows who and why you're here.
Okay.
So because I know that was
sure.
that you did this, but I think you should.
So I'm the president and CEO of ESO. What we have is electronic medical records. We do billing dispatch applications. We also have a few other personal management, some other things. But I think the key for us is we have a lot of data. We're a software as a service company. Our biggest platform that most people probably are now hearing more about than anything else, and where ESO is moving, is that agnostic approach of we'll play with everybody. So health data exchange. We have an enterprise-wide with HCA, so the largest hospital network in the country. We're working with 4 of the top 5 hospital systems in the country who are implementing our stuff. And it allows you to send data in, no matter what EMR platform you're on, or EPCR in EMS's case many times, send it into the hospitals, get them your data, and then also retrieve and bring back all of the data. In the case of HCA, we're taking about 158 data elements. It's not 5. It's a huge data set. It's fantastic, and we're doing a lot with it. So if you look at like the Brent Myers group, they've been doing it. They're our longest-term customer on that in a couple of years. And we're actually moving their Epic stuff this next week as they do a change. But to me, interoperability, bringing all the data back to one place and having the outcome data, where once again now we can prove some things out. It changes the metrics for the industry, I believe, as well, if you could truly know the outcomes. So bringing all the data back to one place and allowing folks to benchmark, no matter what EPCR platform you're on, where you're at, allow anybody to come and play and benchmark and show where you're at in the industry is what ESO's goal and where we're running. And that's on all levels, because right now, we separate financial data from operational data. If I ran my company like that, we'd be out of business, but it is very separate. Those things all need to come together in one place. You need to look at your scheduling and how you staff folks in relation to all of your CAD data and all of your all of your data's got to come together and tell one complete picture, not be in silos within your own organization, not to mention outside of organizations. So we're a data company. Any other questions? Does it seem too big to be possible? I think somebody will do it. I don't know if it'll be us. I hope it's us. I think somebody will do it. I think long term, you just look at where we're at. Something's got to change. Well, thanks.